myself Mukesh Kumar Dhru, roll number 53. Laxatives are drugs that facilitates evacuation of formed stool from the bowel. Purgatives cause evacuation of watery stools. The term laxative, purgatives, and cathartics are often used interchangeably. Classification according to mechanism of action. First, bulk laxative are dietary fiber, bran, methyl cellulose, subgula. Second, stool softeners, docusades, liquid paraffins. Third, stimulant or irritant laxatives, phenolphthalein, bisacodyl, sodium picosulfate, anthraquinone, derivatives, senna, cascara, saccharida. Osmotic laxative, magnesium sulfate, magnesium hydroxide, sodium phosphate, sodium sulfate, sodium potassium tartrate, lactulose, polyethylene glycol. Bulk forming laxative. They are indigestible hydrophilic substance like bran, methyl cellulose, agar, isabgula, etc., which absorb water, swell up, and increase the bulk of stool. They cause mechanical distension, so stimulate peristalsis and promote defecation. It takes 1 to 3 days for evacuation of formed stool. Isabgula is obtained from the seed of Plantago ovata. Large amount of water should be taken with bulk purgatives to avoid intestinal obstruction. Fiber diet should be encouraged in patients with irritable bowel syndrome but should be avoided in those with megacolon or megarectum. The side effects include abdominal discomfort and flatus. Stool softener, stool wetting agents, docusades. Common docusade salts are dicotyl sodium sulfosuccinate, dicotyl calcium sulfosuccinate, and dicotyl potassium sulfosuccinate. They are anionic detergents. They lower the surface tension of stool, thereby cause accumulation of fluid and fatty substance, thus softening the stools. These agents act within 1 to 3 days. They are administered orally or as a retention enema. Docusades increase the absorption of liquid paraffin, hence should not be given together. Liquid paraffin. Liquid paraffin is a mineral oil and is administered orally. It softens stools. It also has a lubricant effect which helps in smooth defecation. It is useful in patients with cardiac disease because it prevents straining during defecation. Stimulant laxatives. These agents have direct action on enteric neurons and GI mucosa. They increase prostaglandin and cyclic adenosine monophosphate levels but inhibit sodium potassium ATPase activity in the intestinal mucosa. This causes an increased secretion of water and electrolytes by the mucosa, thus stimulating peristalsis. The site of action of this drug is in the colon. They cause evacuation of semi-fluid stools. Chronic use of stimulant laxative may cause atonic colon. Large doses may cause loss of fluid and electrolytes. They are contraindicated in pregnancy as they cause reflex stimulation of uterus. Its purgative action was discovered accidentally. The site of action is in the large intestine. It is highly toxic, hence it is not used. Bisacodyl, it is available as an enteric coated oral tablet and also as rectal suppository. It is poorly absorbed after oral administration and undergoes activation of esterases in the bowel, hence the effect is seen only after 6 to 8 hours of oral administration. Therefore, it is usually given at bedtime. Rectal suppositories act more rapidly with an hour. Irritation of rectal mucosa. Bisacodyl is used constipation and to empty the bowel before endoscopy, surgery, and radiological investigation. The side effects are local irritation and inflammation. Osmotic saline laxatives. They are most powerful and rapid acting laxatives They are salt of magnesium, sodium or potassium. They having magnesium or phosphate are known as saline laxative. When given orally, they are not absorbed from the gut, remain in the lumen and exert osmotic effect. They draw water into the lumen, distend the bowel, which then stimulates peristalsis, resulting in purgation. In addition, magnesium salts cause release of cholecystokinin. The mask, the bitter taste, they are often administered with fruit juice. The important osmotic laxative are magnesium sulfate as form salt, magnesium hydroxide, milk of magnesia, sodium phosphate, lactulose, etc. They should be avoided in young children and patients with renal failure, as they may cause CNS or cardiac depression. Sodium phosphate is commonly used orally for colon preparation before surgery and colonoscopy. It can also be used as enema. Sodium salt should be avoided in cardiac patients. Pharmacotherapy of peptic ulcer and gastroesophageal reflux disease. Classification of drugs used in peptic ulcer. Drugs used in peptic ulcer are classified as follows: drugs that inhibit gastric acid secretion, a proton pump inhibitor, omeprazole, esomeprazole, lansoprazole, pantoprazole, rabeprazole, H2 receptor antagonist, H2 blocker, cimetidine, ranitidine, and famotidine, roxetidine, nizatidine. Antimuscarinic agents, anticholinergic drugs, pyrazine, talenzin, prostaglandin analogs, misoprostol, as ansipristal. Ulcer protectives, sucralfate and colloidal bismuth substrate. Drugs that neutralize gastric acid antacids, a systemic antacids, sodium bicarbonate and sodium citrate. Non-systemic antacids, magnesium hydroxide, magnesium trisilicate, aluminum hydroxide, and calcium carbonate. Anti-H. pylori drugs, amoxicillin, tetracycline, clarithromycin, metronidazole, tinidazole, bismuth subsilicate, H2 antagonist, and proton pump inhibitor. Drugs that inhibit gastric acid secretion. Proton pump inhibitor. Proton potassium adipase in the membrane bound enzyme that plays an important role in the final step of gastric secretion. Basal and stimulated. Omeprazole is a prototype drug. The other proton pump inhibitor are lansoprazole, pantoprazole, and rabeprazole. They are products and are activated to sulfonamide at acidic pH as PPI act in the final step of acid secretion. They are effective in inhibiting the activated form, binds covalently with SH group of the proton pump and irreversibly inactivates it. Proton pump inhibitors are administered orally about 30 minutes before food, because food stimulates secretion of acid in the canaliculi of parietal cell, which is necessary for activation of proton pump inhibitor. Through the half-life, proton pump inhibitor is short. Acid secretion is suppressed for up to 24 hours, as they cause irreversible inhibition of proton pumps. In the commonly used doses, proton pump inhibitors suppress and acid production by about 80 to 95%. Their degradation by acid in the stomach is parenteral. Formulation are available of esomeprazole, lansoprazole, pantoprazole, and rabeprazole. They are highly bound to plasma protein, extensively metabolized in liver, and metabolites are excreted in urine. Therapeutic uses: peptic ulcer disease. Proton pump inhibitors are most powerful acid suppressive agents. They inhibit all phases of gastric acid secretion. Proton pump inhibitors are superior to H2 blocker as their onset of acid action is rapid and cause faster ulcer healing. The standard dose omeprazole is 20 milligram and lansoprazole is 30 milligram once daily. Duodenal ulcer requires 4 weeks therapy and gastric ulcer requires 6 to 8 weeks therapy for healing. Mm, Gastroesophageal reflux disease in GERD. The goal of therapy is to produce symptom relief, heal erosive esophagitis, and prevent complication. Proton pump inhibitors are the drug of choice for the treatment of GERD and are usually given once daily. They are more effective than H2 blocker. Patients with erosive esophagitis or peptic ulcer with stricture need prolonged maintenance therapy. Proton pump inhibitor Zollinger Ellison syndrome ZE syndrome is characterized by hypergastrimia with multiple peptic ulcer. Proton pump inhibitor are drug of choice for ZE syndrome. Higher doses of PPI are needed for healing of ulcer. Surgery is definitive treatment in inoperable cases. Prolonged therapy with proton pump inhibitor has been recommended. Thank you.